Hello, welcome to this episode of Building Blocks, a telementoring series that's a part of Project First Line, CDC's National Training Collaborative for Infection Prevention and Control. In the AMA's work with Project First Line, we've heard from physicians that there are significant challenges in facilities outside of the acute hospital setting, places like behavioral health units, post-acute long-term care facilities, to name a few. To help meet these challenges, we developed this telementoring series, bringing in physicians from these settings with IPC experts from across the country. This section will focus on some IPC questions that can arise within acute rehabilitation facilities. These facilities have some unique challenges. They can be standalone or they can be embedded within an acute care hospital. They typically see patients after an acute care stay and often with histories of infectious disease diagnoses. And the patients typically share a large gym or other community room in their rehabilitation program. Before I go through our agenda for the session, I'd like to remind everyone that the opinions expressed in this session are those of the presenters only and do not necessarily reflect the official position of the American Medical Association, U.S. Department of Health and Human Services, the Centers for Disease Control and Prevention, or the presenters' affiliated institutions. There are some ground rules for these sessions. First, this is an all-share, all-learn format, so judging is not appropriate. Disagreeing is not a bad thing, and often disagreements lead to great discussion. There are some areas in infection prevention that need more research, and until then, talking through these details can help us find great and often novel solutions. But we want all language here to remain respectful. For those of you joining in chat and asking questions, please introduce yourself and highlight the state you work in and your role in the healthcare system, physician, nurse, therapist, or other role. We want to tailor our answers to what's most helpful to you. And lastly, please do not put any PHI in the chat, just keep questions general. I'm Dr. Erica Kaufman-West, the Director of Infectious Diseases at the American Medical Association. I'm the physician lead on AMA's Project First Line grant, and I also maintain a clinical practice in Indiana. Now, allow me to introduce our amazing panel. Our presenters today are Dr. Priya Matre and Dr. Leslie Rydberg. Dr. Matre has been an attending physician at Shirley Ryan Ability Lab, formerly the Rehabilitation Institute of Chicago, since 2012. Her clinical areas of focus include neurologic rehabilitation, cancer rehabilitation, and the rehabilitation of medically complex patients. She's involved in resident and medical student teaching and serves as the Assistant Director for Medical Student Education within the Department of PM&R. She is also involved in healthcare quality and safety and serves as the Associate Chief Quality and Safety Officer at Shirley Ryan Ability Lab. Dr. Rydberg is a general physiatrist at the Shirley Ryan Ability Lab with a primary clinical interest in electrodiagnostic medicine, medically complex rehabilitation, and neurorehabilitation. She is an associate professor in the Department of Physical Medicine and Rehabilitation and Medical Education at Northwestern University Feinberg School of Medicine. She is the Henry and Monica Betts Medical Student Education Chair at the Shirley Ryan Ability Lab and is the Associate Residency Program Director for the Northwestern University PM&R program. Our subject matter expert is Dr. James Lewis. Dr. Lewis is the Health Officer for Snohomish County, Washington, and is board certified in internal medicine, preventive medicine, and infectious diseases, and has a master's in public health with a focus in epidemiology. He has been working in public health with a focus on healthcare-associated infections for 7 years. He maintains adjunct volunteer faculty appointments within the UNC School of Medicine, Division of Infectious Diseases, the UNC Gilling School of Global Public Health, as well as the University of Washington School of Medicine in the Division of Allergy and Infectious Diseases. We have 2 cases to work through today, and I think they will hit a lot of the major questions that physicians who care for patients in rehabilitation facilities face. Dr. Matre, if you could present the first case.
Thank you. A 78-year-old patient with a history of frequent UTIs and hypertension is admitted from an acute care hospital 3 weeks after sustaining a left MCA stroke. The patient's impairments include right hemiparesis, aphasia, and severe dysphagia requiring NPO status. During the acute care hospitalization, the patient had a G-tube placed for medication administration, water flushes, and bolus tube feed administration. The acute hospital course was notable for C. difficile infection treated with vancomycin, with the course completed approximately 1 week ago, as well as a UTI treated with cefpodoxime. After admission to the inpatient rehab hospital, the patient is noted to have frequent loose bowel movements with stool incontinence. Due to the high frequency of incontinent bowel movements, therapy is frequently interrupted due to the patient's care needs.
Thank you. And I think this is such a great case because that topic of diarrhea or loose stools and how to manage that in healthcare settings is constantly coming up, both in the acute hospital as well as post-discharge facilities. So in this case, with the ongoing diarrhea, should the physician test for C. difficile given the clinical history? Dr. Matre, how do you typically look at a case like this? Are there clinical steps you take before testing?
Yes, absolutely. Before starting a course of investigation for infection in this type of patient, we typically look for other modifiable factors. We will adjust the bowel medications. Many times patients who come to inpatient rehabilitation facilities may be on multiple stimulants or laxative medications. And then we also look at the tube feed formulas, since many times these by themselves, the different formulas can cause changes to patients' bowel habits. So before making adjustments and starting an infectious workup, we often will change the bowel medications or hold them and work with our dietitians regarding the tube feed medication or tube feed administration.
Great. Now here's the real world application and aspect that we love to bring in. So let's say that despite adjusting the tube feed, stopping some of these bowel stimulant medications that they may have just come in with, the patient continues to have these frequent loose bowel movements and continues to impact their ability to participate in the therapy sessions. So let's say, Dr. Lewis, they do decide at this point, we've got to test for C. difficile. And in their investigation, the PCR is positive, but the toxin EIA is negative. So can you talk about the challenges of C. diff testing, these algorithms, and then how we can help manage patients like this?
Yeah, so this hits on a pretty big controversy, and so you could ask different people and get different answers. And so I'll give some thoughts from my end, but would certainly encourage if you have affiliations with another institution or there's an institution that you routinely get a large amount of referrals from, or primarily as a referral center for you, you could talk to their lab medicine folks and their infection prevention folks and kind of talk about what their approach is and what they think about your specific situation. But certainly, what we found during COVID, I'll just throw out as an example, is that PCRs, which is the initial test there that we mentioned was doing the C. diff PCR, they can remain positive for extended periods of time. Just like people with COVID, we have shown that very clearly. Despite them not really being clinically ill from that pathogen that you're identifying with PCR. And so in this situation, you have someone who recently had C. diff and was treated for it, and now you still have a positive PCR. And then they have other reasons why they might have diarrhea, which you've tried to address, and the diarrhea continues. And so there is potential for a recurrent C. diff infection. That is possible. So in addition to looking at the results you have from the C. diff 2 C. diff tests, you can also look at other clinical laboratory testing to inform this decision as well. So if their white count is normal, that would be an argument against C. diff. If they're otherwise, relatively clinically stable, don't have a lot of abdominal pain, and, you all would know more about this than me if you think that despite your kind of maneuvers to optimize their GI medications and tube feeds, if it would still be reasonable to expect diarrhea in some people, then that would be another potential explanation for this. I would be reassured personally that the toxin is negative and that, despite the PCR being positive, since we would expect that PCR to continue to be positive for some period of time. And so if everything else seemed like there was a reasonable, another reasonable explanation for the diarrhea, and the other clinical signs and symptoms were not concerning, I would be okay with, saying this person likely is not suffering from active C. difficile infection. But again, that approach can vary institution to institution. And so for everyone who's dealing with this, I would recommend talking to the experts within your institutions and coming up with an approach that is consistent. I think that's the most important thing, is to figure out what you're going to do moving forward and doing that consistently for all patients, which I will admit is easier said than done.
No, I think you bring up a good point, is that, often addressing and developing protocols for some of these cases as best you can, trying to factor all of those nuances in, can be helpful, because then it's a standard approach. The nurses always know what to do. The physicians always know what to do. And it can sort of take the guesswork out of the 3 a.m. what do we do question. A second follow-up to this, and I'll go back to Dr. Matre, if you do have a patient who clinically does look like C. diff and the testing is positive, and you think, you know what, this is just a patient that is suffering from this acute infection, what changes do you make in the rehabilitation facility as far as what they can participate in during their treatment, after the treatment? What do you look for from these patients and then the therapy team?
We will initiate contact isolation precautions with therapy in the room at the initiation of testing. So if we have a high clinical suspicion, because the risks of infection to other, or spread of infection to other patients with group therapy is high, if we have a clinical suspicion, the patient will be confined to the room for therapy. After test results come back, we do require a certain duration of treatment and improvement of symptoms with containment before the patient can leave the room. So we do need to balance out treating and testing closely with potential needs for therapy, because testing will potentially affect the patient's rehab course pretty early on.
Yeah, that makes a lot of sense. And we know that in your types of facilities that, rehabilitation, the physical rehabilitation and the group therapies are a really important part of their care plan. Okay, we'll move on to the second case. Dr. Rydberg, if you can present that one.
A 67-year-old patient with a history of idiopathic pulmonary fibrosis is now status post double lung transplant that occurred 9 weeks ago. The patient is now admitted for inpatient rehabilitation after coming directly from the acute care hospital. The patient continues to have respiratory compromise with a tracheostomy in place, using a high humidity tracheostomy collar at night, and is tolerating capping of the tracheostomy tube intermittently during the day. The patient continues to have dysphagia, which is improving, though they remain on a modified diet with pureed solids and thickened liquids. The patient was also diagnosed with COVID-19 infection 10 days ago and currently continues to have a productive cough. The patient's prolonged hospitalization has led to debility with impaired strength and endurance. Their home environment includes stairs, and the physical therapist recommends having the patient practice trials of stairs in the communal therapy gym. The speech therapist also recommends participating in a small group therapy session designed around meals to practice implementing strategies for strengthening swallow and vocal volume.
Thanks. Unfortunately, the last couple of years, these types of cases with COVID-19 have been sadly a high incidence for all of us. But this case actually brings up a few interesting twists on the sort of old song of COVID-19. Let's sort of take a step back from some of those details. And Dr. Rydberg, could you tell us a little bit about how your facility has handled COVID-19 patients, maybe back in the beginning of the pandemic, and then how that's evolved to today?
We've been accommodating people with active COVID infections since April 2020. And so we've really been a part of how to provide rehabilitation in patients with active infections, for years now. And it's become a lot easier once we've developed really clear clearance guidelines from an isolation standpoint. And so ideally, we would clear someone from isolation so that they can go out into the gym, participate in physical therapy, occupational therapy, speech therapy, access all of the equipment, participate in groups, do the stair training as we talked about. And it's pretty straightforward in a patient who is not immunosuppressed, who does not have an open airway, to follow the CDC guidelines and do a standard time-based clearance protocol. But what's been a little bit trickier is these patients who are on high-dose immunosuppressants after a lung transplant, because how does that affect their ability to clear the virus? And what about the tracheostomy with the open airway? So with any type of treatment or cough, they're really, expressing air from lower airways and not just upper airways. And how does that affect the clearance process?
Those are excellent questions. Let's tackle first the question of immunosuppression in general. This particular patient has a lung transplant, but there are many patients on immunosuppression, whether that's chemotherapy, biologics, or other types of immunosuppression that do come down with COVID. Dr. Lewis, how should we approach patients with COVID who are immunosuppressed when we're talking about the duration of isolation?
So, I mean, it's complicated and it's going to be very difficult to come up with a general protocol that's going to fit every scenario. I think, the first thing you would want to make sure is that their symptoms are improving from what they were at baseline. In this situation, you wouldn't necessarily expect this person to become completely asymptomatic due to the other things they have going on. And so you wouldn't necessarily want to wait until they're completely asymptomatic. But as long as they're improving, no longer febrile, that's going to be, a really good clinical sign to say, okay, I think we're getting closer here to being able to stop. The next thing for your clearance protocols, what I would suggest is consider employing an antigen test approach to help with clearance, because certainly immune compromised people can be transmissible for longer periods of time. And I think there was actually a case study published from here in Washington where I think it was someone with lymphoma who had culturable virus for, I think, 3 months after the initial infection. And so we don't know, just because you can culture the virus, are they actually transmissible, or how transmissible are they? So I definitely wouldn't recommend putting people in isolation, for 3 months. But if you have improvement in symptoms and you can get a negative antigen test, particularly if you get 2 that are at least 24 hours apart, I would feel pretty confident in that situation that you could clear them. Now, you can have ongoing antigen positivity. So what do you do in that situation? And then it gets, a lot more difficult. And I think, you could kind of take the enhanced barrier precautions approach, which we didn't talk about with the case around diarrhea, but could potentially have some application there as well. But I did have a couple instances where we were investigating outbreaks in long-term care facilities, never specifically a rehab facility, where were able to one facility in particular had an approach where they were able to rig up a mask to put over very loosely over the tracheostomy site that would still allow for breathing to occur. So that would be potentially one thing, depending on the safety of the patient. If you thought that was reasonable, that could try to help contain those secretions. Particularly if the cough was, infrequent enough to where you think it would be pretty low risk. That could be a situation where, if everything else has kind of failed and you really need to get this person to therapy, that's minimizing, a risk that hopefully is already pretty low if it's been, more than 10 days and they've shown, significant symptomatic improvement. So those would be kind of things I would try to address the current situation, but this one would be a lot harder to protocolize and generalize than the last one.
I agree. I think that this case is definitely very nuanced and very tricky. I think that a lot of times with immunocompromised patients, there are so many different details. It really is helpful if you do have an infectious disease doctor or a hospital epidemiologist that you can reach out to and say, hey, can you just help me through this case? No man is an island, no doctor is an island. And so having a good network of people to be able to reach out to is really important. And I do think it's also important to say that not all immunocompromised patients are not equal. So there are varying degrees of immunosuppression, and different types of immunosuppression hit different parts of the immune system differently. Medications like rituximab, in my experience, have really decimated folks' ability to clear the virus, and they sort of stay positive for a very long time. That's similar probably to that lymphoma patient that Dr. Lewis mentioned. So yes, it can be variable. And so while we'd like to have a nice box to put each patient in and protocolize things as much as possible, these types of patients are very difficult to do that. We know that they require longer periods of isolation, but unfortunately, it's not a one size fits all. Dr. Ryberg, if I could ask, what did you do with this patient when you had to make that decision about, letting them come to the group therapy that was so essential to their recovery?
We are very lucky at our institution to have a fabulous infection prevention team, led by an infectious disease physician from our local acute care hospital. So the protocol that we've kind of worked up is that with an open tracheostomy, we use a 20-day clearance just to give them additional time to clear. And then for patients on immunosuppression, if we deem them to be significantly immunocompromised, then we use a test-based strategy for clearance. We unfortunately don't have access to antigen testing, so we use the resources that we have. So we ended up clearing this patient at about day 20 based on the test-based strategy. And we're also lucky enough that we do have some private gym space that can be used to get patients out of the room and have access to treadmill training, therapy sessions, parallel bars, things like that. And then we additionally have used the gym space, the general gym space at the end of the therapy day. So kind of at like the 4 to 5 p.m. time period so that patients can have access to resources at a time when there's no one else utilizing the space.
That's a great idea to be able to look at what times the gym's not in use or less in use and be able to help patients still access all of the resources that you guys have. One last sort of question that ties into COVID-19 a little bit, and that's just respiratory season in general. We know that between influenza, RSV, other viral respiratory viruses, that season can be quite difficult. For your facilities, Dr. Matre, Dr. Rydberg, are there community sort of markers that you look at? Do you ever have visitor restrictions? How do you look at viral respiratory season? Do you prepare in any way at your facility when you know that that's around the corner?
We do, with our infection prevention team, we do use information from our local community based on infection rates. And with that, in the last few seasons, have changed masking guidelines for staff and visitors, as well as visitor restrictions. So in times of high community rates of various respiratory viruses, influenza, COVID, of course, we may have more strict visitor guidelines where we may decrease the number of visitors at one time. We may have times where we don't allow visitors under the age of 12 or have more strict rules around visitor and staff masking. So we do use community infection rates to help guide our decision points.
Thanks. Dr. Lewis, you come from the public health sphere and more in that community setting. Any thoughts or tips on how facilities can use those types of resources when respiratory season comes?
Yeah, well, that's really great. It sounds like you're already doing the things that I would suggest. Here in Western Washington, we have worked with the regional health departments and the medical organizations in that region. We work together to come up with a strategy to make publicly available the infection rates, and we use syndromic surveillance data. So looking at discharge diagnoses from ERs, which are generally reported by facilities, I think in every state in the United States. And that data is available through state departments of health. And so we publish that data and we use that as a correlative disease activity in the community, and utilized a epidemiologic method called the moving epidemic method to identify thresholds that indicate, when we think we're having epidemic spread of both of RSV, COVID, and influenza. And once we pass that threshold for any one of those viruses, we came up. Public health, in coordination with our healthcare systems, decided that would be reasonable to institute kind of more broad either requirements or recommendations in facilities for masking in healthcare settings. And then coming back down, once all three of those are below that threshold for 2 weeks, then relaxing back to what your baseline kind of policy would be. But it sounds like you're doing something very similar already, and I think that's a really nice way that healthcare and public health can interface and help each other.
Well, I want to thank our panelists today for their inputs and insights, and I want to thank you, our audience, for joining us today. The infections in acute rehab facilities have wide-reaching effects on both patients and their abilities to progress in their care, but also on other staff and patients and their risk for getting an infection from within the facility. We hope that you've learned a little more about how to look at IPC in acute rehabilitation facilities, along with some resources you can use in your practice. We hope to see you again at our other building block sessions. Thank you.